In this lesson, we will be discussing alterations in the integumentary system and the standard of care for patients with skin problems. This lesson is divided into 3 modules. This module will include minor skin irritations and wounds. As previously discussed, skin plays the major role of protection against invasion of microorganisms. Skin problems are common, especially among older adults. Drugs and other interventions can trigger a response or reaction affecting the skin, and skin problems can actually interfere with the medical or surgical treatment of other conditions. After completing this lesson, you will be able to use principles of infection control to prevent transmission when caring for a patient with a skin infection, teach patients and caregivers how to reduce and/or relieve skin pressure, assess the patient for chronic skin conditions, differentiate the manifestations for pressure ulcer categories, and coordinate with the healthcare team to plan an individualized strategy for pressure ulcer prevention and/or treatment for a patient that is at risk for or presently represents with pressure ulcers. Dry skin, also known as xerosis, is a common problem seen as a fine flaking of the stratum corneum. Dryness is worse in older adults and dry climates, higher altitudes, wind, cold, sunlight, and frequent bathing with harsh soaps and hot water. Ways to avoid xerosis are to use a room humidifier during the winter months or when the furnace or heat is in use. Complete your bath or shower every other day. Use tepid water. You can also use superfatted, non-alkaline soap instead of deodorant soap. Be sure to instruct patients to rinse the soap thoroughly. Instruct them to add oil to their bath at the end of the bath. This can aid in avoiding falling. Teach patients to avoid clothing that can rub on the skin. Encourage good fluid intake. Remind patients not to apply drying agents or products to the skin. And you want to encourage patients to avoid caffeine and/or alcohol ingestion. Pruritus is a distressing symptom that may or may not occur with skin disease. It is caused by stimulation of itch-specific nerve fibers. It can be worse at night. Itching with skin lesions is a skin disorder. An example would be like chicken pox. Itching without lesions are caused from systemic diseases such as liver disease or venous disorders. Liver disease causes the buildup of bilirubin in the skin, which causes the itching. The nursing care priority is to prevent skin injury and increasing patient comfort. So as nurses, how can we prevent injury? We can do this by treating with topical or systemic medications, such as antihistamines, topical steroids, sometimes systemic steroids. And then there are other interventions that we could do, such as cutting fingernails short, encouraging mitten use, have a cool environment, promote oatmeal baths, and then provide skin moisturizers. Sunburn is a first-degree or superficial burn and very common related to excessive exposure to the ultraviolet light, causing injury to the dermis, stimulating an inflammatory response. Pain can begin within a few hours after a sunburn has occurred, and it can actually intensify for 1 to 2 days after. Clinical manifestations include redness, tenderness, edema, possibly blisters, headache, nausea, and maybe even fever. Treatment is directed towards promoting comfort. This includes cool baths, using soothing lotions. One example is aloe vera. Might possibly use antibiotic ointments for blisters or topical corticosteroids and or NSAIDs to reduce inflammation and even the possibility of lidocaine for severe sunburns with pain. Urticaria, also known as hives, is white or red edematous papules or plaques of various sizes. Exposures to allergens release histamine in the dermal tissue, leading to blood vessel dilation and leakage of plasma proteins, which lead to formation of lesions or wheals. Allergen triggers are patient-specific. Exact cause is rarely identified but can be associated with medications, certain types of foods, possibly infections, an autoimmune disease, cancer, and or physical stimuli. Management focuses on removal of the triggering substance and relief of symptoms. Because the skin reaction is caused by histamine release, usually antihistamines are used. Patient education should include to avoid alcohol when taking antihistamines because alcohol is a vasodilator and it worsens the hives. It can be sedating as well, and you have an increased risk for falls and decreased breathing. You also want to teach the patient to avoid overexertion and warm environments, which also contribute to blood vessel dilation. What are the causes of skin trauma? They can range from aseptic surgical incisions to a grossly infected draining pressure ulcer with deep tissue destruction. During wound healing, normally there are three phases: the inflammatory phase, the proliferative phase, and the maturation phase. Okay, let's discuss the inflammatory phase. Think of it this way. A highway bridge collapses. There's lots of trauma to the area, lots of damage. Initially causes vasoconstriction and clot formation, such as traffic is backed up and the road is blocked. So then there's the proliferative phase. Just think about this a minute. So about after 10 minutes, you get vasodilation with leaky capillaries. So kind of basically the cars start taking detours, such as white blood cells arrive to clean up the mess. An example of tow trucks arrive to clear out the debris. The term would be fibroblastic. The example is like MoDOT starts to lay the framework to rebuild the roadway and highway and the guardrails, and they start pouring concrete to repair the damage. So basically, our fibrin forms a framework, scaffolding for the new tissue. Fibroblasts attach to the framework and stimulate the secretion of the collagen. Collagen builds the scar tissue, and then the rebuilding phase continues. During the maturation phase, collagen is reorganized to provide optimal strength. Scar is thinner and paler, firm and mature. Sort of like MoDOT is done with the roadside repair. They rebuilt the bridge better and stronger, and it looks just a little bit different than the previous bridge. This wound is healing by what intention? This surgical wound is healing by first intention. Wounds without much tissue loss, such as clean lacerations and/or surgical wounds, are closed with sutures or staples. First intention wounds heal quickly, and since connective tissue repair is minimal, the scarring is minimal too. This wound is healing by which intention? This wound is healing by second intention. Deeper tissue injuries and/or wounds with tissue loss, such as pressure ulcers, result in cavity-like defects that require gradual filling in with connective tissue. If this incision was left open for several days to monitor for signs or symptoms of infection before being sutured, it is healing by which intention? This would be called third intention. Non-sterile wounds at a high infection risk are sometimes left open a few days to monitor for infection. Then they are closed like a first intention wound. Okay, let's discuss depth of injury. There are partial thickness wounds and full thickness wounds. In partial thickness wounds, they are most superficial, involving the dermis and epidermis. These wounds heal by re-epithelialization, production of new skin cells by undamaged epidermal cells in the basal layer of the dermis and the linings around the hair follicles, sweat glands. Skin injury immediately followed by local inflammation. Healing normally occurs in 5 to 7 days in a healthy patient. In full thickness wounds, the damage is so deep, epithelial cells at the base are also damaged, so the wound can't heal by re-epithelialization. Wounds have a big crater and/or cavity that has to be filled with granulation tissue. Rate of wound contraction is dependent on the mobility of the surrounding skin. The more mobile the surrounding the skin, the faster the wound heals. Unlike re-epithelialization, where you get near a normal epithelial barrier, full thickness wounds end up with a weak barrier that is weak and prone to damage again. Basically, you rebuild the bridge, but it's not as good as the original one, and it can only handle bicycle traffic instead of car traffic. The process of wound healing does not last forever. For example, MoDOT will run out of money. So healing slows down or stops in the presence of infection, unrelieved pressure and/or obstacles. Dead tissue supports bacterial growth, obstructs the collagen deposition and wound contraction. Therefore, wound debridement may be necessary to get some wounds to heal. Some chronic wounds may just stop healing for unknown causes, and the only outward sign of that is the failure of the wound to get smaller or an increase in the wound size. Pathophysiology of pressure ulcers are tissue damage that occurs because skin in the underlying soft tissue is compressed between a bony prominence and external surface for an extended period of time. Tissue compression restricts the blood flow to the skin, causing inadequate tissue perfusion and hypoxia, leading to cell death and hence pressure ulcers. Why do we care? It can cause chronic wounds that are slow to heal, cost a bundle to deal with, and can lead to sepsis, kidney failure, infectious arthritis, and osteomyelitis. So who are at risk? These are people with limited mobility and sensory impairment. Other contributing factors include friction and shear forces, inadequate protein intake, and chronically moist skin. Patients with mental status changes, patients who are bedfast, chairfast, poorly nourished, or incontinent patients. Some interventions to use to decrease the potential for pressure ulcers are: use a lift sheet when positioning, use pressure relieving surfaces like foam beds, silicone gel beds, or air beds, reposition the patient at least every 2 hours while in bed or every hour while they are up in the chair, possibly use mechanical lifts or a slide board, place pillows or foam in between the two bony surfaces, keep their heels off the bed surface, like using those POTUS boots or even a heels up cushion. You want to ensure there's adequate fluid intake, at least 2,000 to 3,000 mLs a day. Make sure their diet is rich in protein. Inspect their skin daily. Use daily moisturizer and apply it when they are fresh out of the bath. Avoid prolonged moisture with the skin. May have room humidity. Use moisture barriers if incontinent or near the wound drainage. Keep the skin clean, gentle cleanser and tepid water, not hot water. Use peri wipes that contain a skin barrier agent. And you want to pat dry, never rub, and don't rub bony prominences. The amount of pressure is dependent on the weight experienced at the point of contact, distribution of weight at the point of contact, and density of contacting surface. Pressure is what causes the compression of blood vessels and leads to ischemia, inflammation, and tissue necrosis. Friction occurs when surfaces rub the skin and irritate or directly pull off epithelial tissue. An example of shearing is blood vessels in the skin become kinked or obstructed, and that leads to inadequate tissue perfusion and breakdown. We identify patients at risk for pressure ulcers by using the Braden scale, as you note here on this slide. You may also review the Braden scale on page 478 of your textbook. The Braden scale addresses categories of sensory perception, moisture, activity, mobility, nutrition, and friction and/or shear. There are stages to pressure ulcers. These are suspected deep tissue injury. The area will appear purple to maroon in color, can have a blood-filled blister present, and may be painful. It's felt either firm or boggy, mushy. It can be warm or cooler than the surrounding tissue prior to this discoloration. In stage 1, the skin will still be intact, the area will appear red and does not blanch, and it's usually over a bony prominence. In stage 2, the skin is broken. The ulcer is superficial, causing partial thickness loss of the epidermis and the dermis, and may appear as a blister or a shallow crater, and or an abrasion with no bruising. Stage 3 includes full thickness skin loss. The subcutaneous tissue is damaged or necrotic. Damage goes down to the muscle fascia. Stage 4 includes full thickness loss with exposed muscle, palpable muscle, tendon, and bone. Unstageable is full thickness and base is completely eroded and covered with eschar, obscuring the true depth of the wound. There is a chart 27-3 on page 480 of your textbook that describes the stages of pressure ulcers in detail and pictures them on page 481 of your textbook. So what stage of pressure ulcer is this one and why? This is stage 1. Because the skin is intact, the area is over a bony prominence, the area is red and does not blanch with external pressure, and the borders appear defined. What stage of pressure ulcer is this one and why? This is a stage 2. Because the skin is not intact, there is partial thickness loss of the epidermis or dermis, and it is characterized as an abrasion, a blister, or shallow crater. What stage of pressure ulcer is this one and why? This is stage 3. The skin loss is full thickness. There is subcutaneous tissue damage. The damage does not extend to the bone, the tendons, or the muscles. And the wound has a crater-like appearance. So what stage of pressure ulcer is this one and why? This pressure ulcer is a stage 4. Because there is a full thickness skin loss, there is exposed bone, muscle, and or tendon. It will often include undermining and tunneling, and slough and eschar are often present. Eschar can be black, gray, brown, is non-viable, and is denatured collagen. Undermining is the separation of skin layers at the wound margins from underlying granulation tissue. And then remember, unstageable is the process of full thickness skin loss, and the base is completely covered with slough or eschar, obscuring the true depth of the wound. The dressing on pressure ulcers can make a huge difference. It needs to remove unwanted debris from the surface of the ulcer, protect exposed healthy tissue, and create a barrier between the ulcer and the environment. There is mechanical debridement and natural debridement, which can promote self-digestion of the dead tissue by autolysis. If dressings are too wet, then it keeps the new tissue mushy, but a dry dressing dry out the new tissue. Dressings are usually changed every 4 to 6 hours. Dressings can be hydrophobic. It keeps the wound is mostly free of drainage, and it just needs protection from the environment. And then dressings can also be hydrophilic, which draws the moisture away from the wound. Non-surgical management of wounds also include physical therapy, drug therapy, and nutritional therapy. Physical therapy can include daily whirlpool, dressing changes, debridement, and then to help remove the dead tissue. Drug therapy will include topical antibiotics if an infection is present. They will need a well-balanced diet rich in protein, carbohydrate, vitamin C, and zinc. For non-surgical management of wounds, we also have electrical stimulation and vacuum-assisted wound closure. Electrical stimulation can include low voltage pulsating current to wound area, promote blood vessel growth and granulation. It's usually done an hour a day, 5 to 7 times a week. There are single or multiple electrodes, and it is contraindicated in patients with pacemakers. Vacuum-assisted wound closure is a suction tube that is covered by a special sponge and sealed for 48 hours. It's on continuous low-level negative pressure that is applied. Its effectiveness is dependent on the seal. Can have bleeding complication if they are on anticoagulants, and you do not want to use near skin that has cancer. And the other non-surgical management of wounds is hyperbaric oxygen therapy. Hyperbaric oxygen therapy consists of high-pressure oxygen. It raises the tissue oxygen concentration. It's expensive. It's safe for a life or limb-threatening wound. And then it enhances the white blood cell's potential to kill the bacteria, and treatment lasts from 60 to 90 minutes. Wound eligibility for this treatment are burns, necrotizing soft tissue infections, brown recluse spider bites, and osteomyelitis. Surgical management of wounds is the removal of necrotic tissue, skin grafting, or the use of muscle flaps to close wounds. Surgical debridement can happen at bedside, treatment room, or in the OR, and you want to make sure the patient receives sedation and/or local anesthetic. Grafting is used for wound closure when full-thickness ulcers are unable to close. Grafting is because wounds cannot close or provide natural healing, which can result in loss of joint function. It is unacceptable to do grafting for cosmetic appearance. There is also unacceptable to do grafting if there's a high potential for wound reoccurrence. Post-op care includes to immobilize the graft site with cotton dressing for 3 to 5 days, and do not disturb the dressing, and elevate and immobilize the site. After the dressing has been removed, monitor for non-adherence, necrosis, and changes in color. Immediate post-op can include pressure dressing, Pain management to medicate before the dressing changes. I want to check every 4 hours for pain, especially at the donor site, and then you want to monitor for pulses of affected extremity for the graft healing process. This concludes Module 1. If you have any questions related to the course content, contact the instructor.